Right. Welcome everybody to the March 3rd town hall. This is a Debbie's Dream webinar where we're going to basically in gastroesophageal cancers and then take a bunch of questions from you all, which we're happy to try to get to as many as possible in the hour. There is another one of these coming up in a little while, so there'll be some more webinars and educational opportunities. I'm Sam Klempner. I'm a GI oncologist at Mass General in Boston, and I'm going to be the moderator. And I'm joined today by two real leaders in gastric and esophageal cancers, Dr. Jaffer Ajani and Dr. Zev Weinberg. So this should be a great session. I'll let them introduce themselves. So, Jaffer, please go ahead and introduce yourself.
Yeah, hi everyone. Jaffer Ajani from MD Anderson. I mainly treat gastric and esophageal cancers and thankful to DDF for inviting me. Thanks, Sam.
Awesome. And Zev?
Hi, Zev Weinberg from UCLA and GI Oncology, and happy to be here as well.
Awesome. Yes, thanks for taking the time out of busy days. I know Monday's always busy. I want to start off and trying to get to know the people that come to these webinars so we can really tailor them and make sure that we are addressing the key questions that coming from the patient community. So there's a couple poll questions I'm going to go through quickly. You can see them right now if you don't mind answering. This is really just a way to understand the audience and make sure that we're covering topics that you guys want to hear. So you can see the questions there. What is your relation to stomach cancer? So patient, survivor, long-term survivor, caregiver, or family member, friend of a patient. Just take a minute if you don't mind. Perfect. So for those that can't see, about half of people are currently patients on active treatment. And then it's sort of a range of all the other categories. 10–15% of people, caregivers, or unfortunately, survivors from a loved one that passed away from this difficult disease. So I'm going to lead this off. We'll have a little bit of me asking Jaffer and Zev some clinical scenarios just that come up a lot, and then we'll get to some questions. So Jaffer, maybe I'll come to you with this one and then similar question to Zev. But in the last town hall, we had a bunch of conversations about patients who are PD-L1 positive and Claudin positive. And how are you thinking through this scenario? Are you using specific PDL1 cutoffs? You do have a way that you kind of think through it, or patient by patient?
No, I actually use PDL1 CPS cutoff.
Mhm.
So if it is 5 or higher, so if a patient has a tumor that is double positive, that's what I think you're mentioning. So Claudin very high, and if the CPS is 5 or greater, then I would choose chemo plus immunotherapy. If the CPS is PDL1 is still positive and it's from 1 to 4, then you could choose chemo and the new drug zolbetuximab. And I think of course, we need more data. And we are hoping that in the future we can combine both drugs and produce a greater advantage.
Yeah, I think a lot of people waiting for that type of data. Zev, similar question to you in patients, because a lot of our patients are PDL1 positive to some degree. How do you sort of think about this question?
Yeah, I think similar. I mean, I do think it has to be individualized, right? It's a biomarker that is um, been around for a while, but I think if you have a good CPS score, I'm usually using that first. So far, that's been my experience. These are individual things, though, that, depending on how strong a Claudin biomarker is and, um, how low the CPS score is, that would certainly change my opinion. So certainly it's something that does need to be individualized.
Yeah, I completely agree. I think clearly in the PDL1 negative patients, zolbetuximab makes probably the most sense, and then everyone else is definitely some degree of variability. Maybe Jaffer, since this is still a new drug and you've been involved sort of in these studies, spotlighting particular, maybe just give the audience real high level Claudin, what is it, and what was the data?
Right. So it's a brand new biomarker, and we're really happy to have another target, so to speak, that we can use a drug to disrupt that protein. So claudin is physiologically present in most of our tissues, and its function is to keep normal cells together. And if you think about it, normal cells are not really looking to migrate or multiply. Some do, but most of them are just happy to be attached to another normal cell. And in that context, the claudin is like a tumor suppressor. It's preventing the cell is tying down to is migrating out. So it's like a tumor suppressor. But the cancer cells cannot live like that. So cancer cells are focused on survival tactics, and one of them is to multiply, other one is to migrate out. So they have to cut this protein. Claudin is cut, and when you cut it, it becomes a tumor supporting protein. It becomes an oncogene, and also it can be targeted. It's not hidden like it's in normal tissue. So it just happened that some of the earlier studies started in Europe, in Germany, and produced results that seem very interesting, intriguing. And this was followed up by a Japanese company that did 2 phase 3 trials, and they're both positive. I mean, they're both producing advantage. So if you think back, 3 years ago, the claudin positive tumor patient that you and I were treating, we were just giving them chemotherapy. Now we can add another drug and achieve some advantage. I mean, it's not it's not curing. We don't know that because we need much longer follow-up like we have with immune therapy.
Mhm. Mhm.
So the drug can produce some side effects. So one of them is like 16-17% of patients can have significant nausea, vomiting, and this has to be sort of recognized by the treating team, taught to the patient, and managed during treatment, and of course in subsequent treatment. So there is a learning curve because many oncologists in the United States, they haven't used this drug yet. So I think it's going to be an educational challenge.
Yeah, I think that's certainly something we'll probably come back to even in this webinar as well. So now we've got Claudin, HER2, PD-L1, MSI as sort of the core biomarkers that you kind of need to know about any advanced disease patient. But the theme of this session, one of them is novel therapies that aren't approved yet and things that are coming. And Zev, I'm going to come to you because you've done a lot with the FGFR2 story. So maybe sort of similar high level FGFR2 prevalence and what's the early data we've seen so far and what are we waiting for?
Okay, so FGFR2, thanks for the question. FGFR2 has been an interest of mine for about a decade now. And it's kind of divided into 2 categories. One is amplification, which is about 4 to 6% of gastric cancer, which itself is associated with mostly diffuse type gastric cancer. And that's true genetic amplification. And the other group, which is mainly a protein overexpression category, similar to HER2 and similar to Claudin 18, is when the protein, even though there's no amplification of the gene per se, you do see protein overexpression as measured by immunohistochemistry. And in the studies that have been done, that probably represents up to 20% of HER2 negative gastric cancer. We haven't really tested that in HER2 positive gastric cancer. So HER2 negative gastric cancer, which includes all the CPS and all the Claudin patients, it's probably another 20%. Now, in the most recent studies, what we're trying to do with the FGFR targeted approach, at least with the first group of the biggest trials out there, which are the bemarituzumab antibody trials, even looking at a higher cutoff such that the requirement of staining is even more scrutinized. And so it's probably about 15 to 18% of HER2 negative gastric cancer. And that's the subject of the two large randomized phase 3 trials that have completed enrollment, but for which we don't know results, which are Fortitude 101 and Fortitude 102, both of whom are asking the same question, either with FOLFOX alone in one or FOLFOX plus Nivo in the other. Does the addition of bemarituzumab, this monoclonal antibody against FGFR2b, improve outcomes? And so the results will both be available with any luck by the end of 2025, because they were both launched at the same time. One is a little longer than the other.
Yeah, that's awesome. So we may, not too long in the future, we'll have more to talk about and even more complicated scenarios clinically to bring up.
Hopefully.
Another theme that comes up, and I asked the last panelists similar questions, is sort of post-progression on targeted therapy biopsy samples. So we all know that people with HER2 positive disease, they get trastuzumab and unfortunately ultimately progress in many cases. And then we debate about should we biopsy, should we retest? And Jaffer, are you thinking the same for Claudin? If someone is progressing post zolbetuximab and you have some of these ADC trial potentially available, or just in general, or are you thinking about repeat biopsy for this scenario?
This is a very complicated question because, and I don't know if we have time for this, but for patients, I think we can mention that, the tumor cells are driven by some protein. And again, these proteins are helping to multiply and migrate and do many other survival things. But the context is very important. So there can be left side of the tumor is depending on one protein, the right side can be depending on another protein. So this is also mentioned as heterogeneity, and it's a very complicated and very challenging issue. So actually, Zeb and I are helping College of American Pathologists and ASCO, American Society of Clinical Oncology, to revise the HER2 guidelines. And there, I think we might end up saying what you just said, Sam, is to repeat the biopsy. And it is not flawless. I mean, your biopsy can be negative because you biopsied on the wrong place. So maybe liquid biopsy, which is taking a blood sample and looking for certain things, may help with this. But right now, I think for HER2 space, if there is progression of cancer after first-line treatment, then I tend to biopsy, and I tend to biopsy when it's feasible, the metastatic cancer rather than primary, because as we are learning that the profile of the primary can be different than profile of the metastases. Profile of the metastases in the liver can be different than ovarian metastases. So this is really challenging. And still we are lucky to have some drugs that produce advantage. So it's going to be an ongoing challenge. And we are hoping to have better platforms, better reliable blood tests that might help us better.
Yeah, I think totally agree. I think our own practice here has similarly been to biopsy when feasible and safe, partly for research purposes and partly for clinical information. reminds me of a question that I wanted to ask the audience in a poll, which is about biomarkers. And so maybe if we can bring that up. Yes, there you go. So just to understand sort of the biomarker landscape of people who are here, first question is, if you had a biomarker, which was it on here? And then did you test positive for any of the biomarkers? And I see the votes coming in pretty real time now. So a couple encouraging things here out of the 20 or so people that have voted so far. Basically, 83% said they were positive for a biomarker. And I think that's about right. You know, most people are positive for one out of all of these. And then if you say yes, maybe we can pull that result up. Well, I'll read it. So out of the 20 people who answered, 47% of people were positive for Claudin 18.2. So, and 33% of the people here are positive for HER2. No one had FGFR2 testing. That's probably not a surprise. And 2 out of 15 people were positive, were MSI high. So this interesting group of people who are here, clearly people who have selected for testing. Maybe Zev, I'll go even farther back because this is another thing that is probably one of the bigger differences between academia and community is ancillary services. So someone comes into your clinic as a new gastric cancer, let's say metastatic. You know, what's sort of the composition of the team? Is it nutrition? Is it oncology? Is it everyone sees the patient? Just who are sort of the core team members?
So, I mean, it's stage dependent, you know, and you have someone with advanced stage disease, unfortunately, where surgery is not an option, then, you know, we don't usually get them too involved, unless there's some necessity in that direction. We do have everybody get seen by the medical oncologist, usually, obviously a nurse practitioner or advanced care practitioner. We have everybody get seen now by palliative care provider to help with pain management, GI issues, and a nutrition care specialist. So those are the core if you have advanced disease. And if you have localized disease, we usually add in there a GI doctor, certainly, and the surgeon. And also those, you know, each one of those has their own group of advanced care practitioners who work with them. So, you know, it is a multidisciplinary disease. We need to keep it a multidisciplinary disease, I think, if we're going to offer patients, you know, high quality care. It's a necessity to have not just one doctor dominate everything, but even in advanced disease, I don't think, you know, we're at the age now where certainly we have these people who specialize in palliation, who can be quite specific for a certain cancer, and nutrition, and we should probably, you know, get them involved in a lot more cases.
I totally agree. I think removing the stigma from palliative care is a big part of improving the, you know, overall symptom management for patients. Before we move on to the Q&A, because there's going to be probably a fair number of questions that come in. There's one in the chat that caught my eye, and Jaffer, I'm going to come back to you because you opened the door for heterogeneity. But there is a question about if someone is HER2 amplified on ctDNA but negative by IHC, let's say it's a second or third line situation. How do you think about that?
Right. So that's a very good question. And I hope that we will bring it to the new guidelines. So again, you know, if you think about it, first of all, let's go reverse. If the HER2 is overexpressed or abundant HER2 protein on the surface of cancer cell, DNA is usually amplified. 85% of the DNA will have extra copies of the genes. So most of us have only 2 copies of HER2, one from our mom and one from our dad. But cancers can multiply the number to to its advantage. That cell wants to use the HER2 protein again to survive. So if you take a sample, tissue sample, and in the blood you already got extra copies of RB2 gene, I would say go with the RB2 gene because you may have biopsied the wrong place and HER2 is not being expressed there. So that's how I would approach, but this is not in the guidelines. I think we will have to sort of address that. But it's a beautiful question, no question about that.
Yeah, I think limitations to IHC and fish for sure, and it does come up once in a while. And unfortunately, it's often tricky for trials and eligibility for our studies that we have. Dev, I'll ask you about more about HER2. So we've been waiting on this trial, Destiny Gastric 04, that maybe will clarify or unify second line practices to some degree. Just for the people here, maybe just what is the question of the study and what are we hoping to address?
Yeah, it's a good question because it made the news. So, Destiny
Exactly.
Gastric 04 was a study done ex-US because we've had TDXD approved in this country for a number of years, so it's hard to practically enroll. And the study randomized patients to either TDXD, which again has been approved for a few years here in more refractory settings of gastric cancer, or paclitaxel ramucirumab, so no anti-HER2 therapy at all. And the press release just came out the other day that showed that the study met its primary endpoint, implying that the survival of patients who got TDXD was better than the patients who got paclitaxel ramucirumab. And sort of, we've been using TDXD for a lot of patients here now for second and third line. So maybe not having dramatic changes in our practice in this country, but certainly validating. Now, we all know you can only learn so much from a press release, and so all that I saw, at least in the press release, was that it met its endpoint of survival. We don't know all of the questions which we should know, which is, how many of these patients did have biopsies to confirm HER2, how many had some of it on circulating tumor DNA. I think some of that might get teased out, I hope, in the actual presentation, which, I hope will be at one of the next few meetings, I imagine. So it's good to see it because I think it sort of tells us we have a drug now that was accelerated approved and had data in the refractory setting, now proved to really be, it seems, the preferred choice in second line.
Yeah, totally agree. That I think that's all anyone has seen is the press release from it may have even been today that the trial was positive. Jaffer, I'm going to come to you with a question also from the chat, which is about EBV. So you've been involved in, since the beginning, molecular characterization of gastric cancer and TCGA and the clinical impacts of some of these molecular subtypes. But there's a question in the chat about an EBV positive gastric cancer that's PD-L1 positive and Claudin positive. And maybe just take a step back and tell us a little bit about how common is EBV positive gastric cancer? What are sort of the features of that? Are you surprised by this PD-L1 score?
Right. So EBV is a virus that can actually get incorporated in the DNA of normal cells and then eventually can result in so-called EBV-induced cancer. And it being a virus, our immune system is very adept in identifying viruses. So, and even then, that is kind of sort of strange that EBV-induced cancers occur, very uncommon. Usually confined to the stomach, it's not in the esophagus. And they are highly responsive to immunotherapy. So they could be considered very similar to MSI high tumors. And even if claudine is positive, and one would not necessarily worry about the CPS score, higher the better, but doesn't have to be. So if you confirm that the tumor is EBV induced, and there is a test for that, then you just use immunotherapy. The limited literature out there suggests that they are highly responsive to immunotherapy. Whether you use one drug or two drugs is kind of open.
Like she likes that thing behind
So
the door. I can hear it from
I
up
would
here.
acknowledge the other biomarkers, but would not, in other words, I wouldn't combine zolbetuximab with
Crawling on the floor right now.
immunotherapy if they're double positive.
Yeah, so many interesting questions about sequencing of all these drugs, and do we need to throw the kitchen sink in the beginning, or can we be a little thoughtful about preserving agents with activity for subsequently? Speaking of that, Zeb, this is an impossible question, so maybe I'll rephrase it a little bit, but Essie writes in the chat, what is the best clinical trial or standard for a patient who is high Claudin 18.2? I think obviously we don't know what is the best clinical trial ever. That's why we do the trials, in part. But if you
Yeah, I
have
mean,
a
I
new,
think that what Essie's getting at here is high Claudin, and we have a drug, zolbetuximab. We have other drugs that are investigational, like a lot of these antibody drug conjugates that seem active too for high Claudin expressed in tumors. But I would agree with Dr. Ajani that, not everything should be combined together. We've had a lot of experiences with cancer and gastric cancer in particular, where this idea that all of a sudden, if you just add more drugs in the front, that's necessarily better than sequencing drugs is not always the case. We can look at a very recent negative press release and something called the LEAP study that added lenvatinib and pembrolizumab together with chemotherapy did not improve outcomes, it seems, according to the press release. So again, it's not always that more is better. You can ask a question about more is better and do it in the proper way, and but sometimes you run into trouble, and that has to do with side effects primarily, or drug-drug interactions, which are sometimes unforeseen. So the Claudin 18.2 positive high expression, if that means more than 75%, I think that certainly makes sense to use zolbetuximab in some contexts. There's also a whole lot of these other Claudin 18.2 drugs being investigated that are, again, a lot of them may be better than zolbetuximab or may be combinable in different ways. So I think it really depends on the individual case.
yeah, I agree. Maybe, Jaffer, I'll come to you with sort of a extension of this question. Let's say you've had someone who's been on Folfox and nivolumab or Folfox Nivo and some novel IO agent in a frontline trial, and then they progress and you know that they're Claudin positive. If you're in a second line position, are you looking at, let's say you have everything available to you, including antibody drug conjugate trials for Claudin 18.2. Are you looking to leverage and exploit that target as soon as possible, sort of in second line? Or are you thinking about keeping it for later, even though understanding that there's no approved drugs, but let's say you have everything at your disposal, like you probably do at MD Anderson?
Yeah, so I think it's a very good question. We are going to have, more biomarkers we do, which is really good for our patients. In other words, more biomarkers are valid to be tested. You're going to have double positive, triple positive, and so on. And like Zev mentioned, you cannot add 2 or 3 targeted agents. I mean, you can add, but the problem is you will have significant toxicity, and that's not good for the patients. So you may target 1 or 2 positive biomarker in the beginning, and then you might save some for later on. So I think in some aspect, the second line and third line treatments are going to get better as we move forward with more targets or biomarkers. So in this particular case, there's a lot of interest in pursuing Claudine in ADC environment, bispecifics. These are just new technologies. But one question that is not yet answered is whether if you use Claudine-directed treatment in the beginning, which is not the case in this scenario, can we reuse? I mean, can you retarget Claudine? I would really like to know because we got so many molecules out there with different payloads. So one time you take one payload, and if that fails, you can use same target with another payload. And this is already happening in breast cancer. So, but in this particular scenario where Claudine was not targeted, I would really look for a trial for Claudine ADC or bispecific. And of course, we need to continue to profile. Maybe, we can discuss going beyond the primary biomarkers. So primary biomarkers will be microsatellite status, HER2 status, PD-L1 status, Claudine status, maybe EBV in some case. But later on, we still need to find more targets to choose for appropriate clinical trials. So, I would do that in a second line setting.
I totally agree. We just opened the Clarity phase 3 study here, which is another Claudin directed ADC.
Hello.
Yep, we can hear you.
Yeah, thank you so much. Sorry, I was trying to check my speakers. And first of all, thank you for this opportunity to ask the questions to doctors. I'm from Yerevan, Armenia, a country very, very far from the US. And I have so my dad is a stage 3 stomach cancer, and we have done 4 cycles of FLOT pre-total gastrectomy. 1 month ago, we did a total gastrectomy. Now from today, actually, we are starting the 5th cycle of FLOT, so post gastrectomy. And I had a question about, I have submitted a question before the meeting. I'll try to keep it short to respect everyone's time. So we have tested before the gastrectomy for MSI, and he was pMMR, but we haven't done HER2, we haven't done other biomarkers like CDL1 and others. And now the sort of the standard treatment that our oncologists are offering is FLOT, post-gastrectomy. But I was reading I have done a bit of a research, and I think there were positive cases of trials where actually targeted therapy was added to FLOT for stage 3 gastric cancers, and it had a very good positive response versus FLOT only. So I wanted to check how, well, first of all, it's not a standard treatment as far as I understand, but is it something that I should advocate for with my oncologists, A, and B, so on the biopsy, post-gastrectomy biopsy, the lab didn't do HER2, and when I tried to bring it up with my oncologist saying, hey, should I test it for HER2 as well, since we have the tissue, they told me that no, it is not necessary at this stage because we normally test for HER2 and other biomarkers when there is a metastasis and so on. And also right now it doesn't make sense to test it because A, it will not affect our treatment, and B, the tissue, the cancer can mutate at a later stage, so it can give us a false sort of false positive, or not false positive, but it can affect our treatment later on. So it's better not to do HER2 now. So just wanted to check that how consistent is this with your practices, with your experience from the international perspective? Thank you very much.
Perfect. Yeah, lot in that question, all sort of relevant to the future of gastric and esophageal cancers. So Zev, I'll come to you with this one, and maybe I'll boil it down to a couple tangible things. So one, talk about just the standard for perioperative. Maybe touch on some of the data for HER2 and what we know about PD-L1 as maybe the targeted agents that have been considered added to standard perioperative FLOT. And do you test in localized cases?
Yeah, so I think the honest truth is that I sort of agree with your oncologists out there, which is that at the moment, we don't add those drugs routinely. At least I don't, and I could not speak for every practitioner, but those studies haven't been completed. Well, there may be some hints of some good results. We've been doing this for a long time, and you kind of know that you have to do the right studies to see the proper results. You can always sort of practice by anecdote, but it is dangerous because we don't really know that approach is the right one. So in particular, in localized gastric cancer, I think for now the standard of care is FLOT, and that's what I usually do. I'm not sure that every one of these drugs that necessarily has activity and advanced disease will work in earlier lines. We hope that that is the case. So far with immunotherapy, it's not yet worked out, although there's one large study still pending. And the HER2 studies, it's been a very mixed story. So I think we need to see more data. So to answer your question, Hake, I would certainly consider FLOT to be a very appropriate option still.
Yeah, I agree. I think that's global standard. And until we have phase 3 data, it's hard to deviate from something like that when you're going for cure. Someone wrote in a question about germline mutations. So Jaffer, I'll come to you with this one. So maybe speak to the most common germline alterations in gastric cancer and sort of how do you handle a positive?
Right. So this is one thing we ignore regularly in the clinic. So I can be going from one room to another, to another, to another, and not really bother about the germline profile of the patient, which I think will become very important as we go forward. There's a beautiful study from Japan published in New England Journal, I think in 2023. And they were interested in H. pylori, the bacteria, and incidence of gastric cancer under certain circumstances like presence of H. pylori infection and presence or absence of certain germline changes. And what they found was, something very interesting that individuals, and they had a very large control, like 40,000 control and 10,000 patients. And what they showed was that if there is some sort of germline deficiency, that you cannot repair your damaged DNA, and you have H. pylori also, you have a very high incidence of gastric cancer. It's like 45% for lifetime. But if you just have H. pylori, it's under 14%. If you just have DNA damage deficiency in one of the genes, and they tested only limited number of genes, there is still some increase in gastric cancer, but combination is very important. So I think and this we completely ignore. So patients will ask, why did I get gastric cancer? Well, a lot of times you can't really answer that because you don't check this and that. So I think the other one, really famous one, is the CDH1, which is the familial hereditary diffuse type of gastric cancer. And now the guidelines, NCCN guidelines, and I think the the familial groups that also recommend some guidelines are recommending that if you have a diffuse type of gastric cancer, you should get germline CDH1 done. And this is not only for young people, and that topic we don't have time today, but even for older people, you may have inherited like a mutation in a gene like CDH1, and then if you have it, then it has effect on your family. So I think going forward, I hope that we will be doing like a germline testing on a regular basis. And at MD Anderson, we just begun a project to do 250,000 cases, whole genome sequencing. And we'll see, hopefully that will provide some guidance as to where to go in the future.
Yeah, seems like every time we look in big studies like that, it's always surprising to see the percentage of patients that are found to have some potentially um, modulating alteration in the germline. Not always the classical ones, but we see a bunch of new stuff. Zev, come to you with this topical question that came in ahead of time that I missed, which is about MSI in the neoadjuvant or perioperative space. So someone writes in that their father is a healthy 70-year-old, had a T3 gastric cancer recently diagnosed. Sounds like it was about 5 centimeters. The primary tumor, no Mets. Staging lap was negative, PET was negative, and the patient is MSI high. Started on Nivo IPI, aligned with some of what's in the NCCN from Jaffer and the rest of us. And the goal is, of course, cure. But this touches on, the need for radical surgeries in this patient population, whether or not there are ways to identify people who can avoid it. So if you have a MSI high, let's call it a T3N0, since there's no nodes mentioned here, and the patient is, let's say, responding to ipi-nivo, how do you sort of walk through the next steps?
Yeah, it's a really good question. And there are certain cases where, we just don't have the high enough volume to probably answer all these questions in a randomized trial. So we do have to make do with what we have here. I do think if someone's got a good response to that and is not a surgical candidate, for whatever reason, or declined surgery for whatever reason, then, it's certainly reasonable to do observation and do frequent endoscopies and all the CAT scans just in a much more aggressive manner, maybe to make sure that we're not missing something. If someone's still a fit person and is after a period of immunotherapy and still wants to have the tumor removed and the surgeon's cleared a patient, I think still surgery is the standard here. And a lot of times, you get rid of the tumor, and of course you're going to have a great pathological response and get rid of some lymph nodes, but the surgery needn't to be necessarily as aggressive, perhaps, as it would have been. And number two, um, there is sometimes, value to removal of the primary tumor, even in the context of a nice response to pathologically. So I think that's the way I think about this problem, recognizing that we probably will never have randomized data here. So we have to sort of look at the independent data sets and try to make informed decisions.
Yeah, I agree. Jaffer, I'm going to ask you sort of a slightly twisted version of the question. So since, you and your group have put out some data on sort of 6 months of neoadjuvant therapy in MSI high pan cancer papers, and then in rectal cancer, we see that, maybe longer periods of neoadjuvant therapy are associated with higher pathologic complete response. So if you have a patient who's sort of on this non-operative path, what is sort of your duration of neoadjuvant immunotherapy before you'd say, we either need to make a call, like if someone has residual tumor after 6 months of neoadjuvant immunotherapy, probably month number 7 is not going to be the answer. They probably need surgery. But is there a kind of a time limit that you put on this?
Not really. Longer, longer we can give immunotherapy, that's better. And one thing Zev mentioned is very important is to not let one doctor make a decision, especially in potentially curable situation. So what we do is, I will take the case to multidisciplinary conference, not only once, take twice, three times, as many times as needed. Get everybody's opinion and make it sort of a combined decision. And that is best for the patient because one doctor, no matter how experienced they are, sometimes they can make a mistake and the patient is the one to catch it. So this particular area that we are discussing now is fairly new and very exciting. And so what I am doing in my group is we are treating with immunotherapy, often with nivo-ipi, and we're taking the patient back to every 3 months to the multidisciplinary team, and we do the endoscopy and a good quality scan, and then we make a decision whether, is this time for surgery or just continue immunotherapy. If there's a response, we continue till there's no longer a response and there's residual tumor, then you have to consider local therapy.
Yeah.
But there is no general algorithm nationwide. So I think things are happening slightly differently in different institutions.
Yeah. I think we're pretty similar to both you and Zev in terms of general approach. Willing to give people potential opportunity for non-surgical management, but understanding that, the biology is ultimately the key and we don't want to miss a window for a cure. Someone wrote a question in the chat about if path CR is achieved, why do surgery at all? Just really, really briefly, path CR, unfortunately, you don't know a path CR until you have the operation. So clinical complete response where the tumor is gone on a scan and on an endoscopy is different than a pathologic complete response, which means the tumor's out of the body. So I would just clarify that point. So
I sent you a whole list of questions.
pick a top one.
Dr. Ajani saved my husband's life, by the way. So, my husband was one of those that he's on his third oncologist, and I had to keep asking doctors to actually talk to him. And finally, I found one that was like, he's the top of our field. And I was like, yes, you're the doctor. So, my main question is, and Dr. Ajani had recommended this actually to his oncologist, but I agree with what Allison was saying because her husband just died. And I feel like Jordan's kind of on that path, unfortunately, of he's on in her too. He ended up in the hospital 3 times in February. Like Jordan got to the point he's like, I'm so glad that February is over because I thought it was going to kill me. So I'm kind of on the same spot that she is of, okay, do we just keep doing treatment and treatment and treatment? I mean, at what point is it quality versus quantity of life? And I have doctors in the hospital that aren't oncologists saying you need to get hospice. I have doctors that are oncologists saying you can do chemo until he freaking dies. And they just put him on a feeding tube. So I guess my other question that I'm asking is, okay, is it I need to start preparing for end of life things, or at what point do you guys recommend just stop treatment?
That is a super difficult question that I don't think is going to be probably possible to answer. It's a very personal decision about people's goals and what does quality mean for one person to another person. But I will let Jaffer start off, sort of very broadly speaking about maybe how many lines of therapy do we have evidence for, and then where do you start to have these conversations about, we're running on limited time.
Yeah. Sorry about that. So what happens in the clinic, the patient's journey, and I'm talking about starting with stage 4 cancer. Once the first line fails, it's a downhill course for most patients because we don't really have very good treatments after that. Exceptions are there. Sometimes with HER2 positive, we can get some mileage out of a drug like Enhertu. But a lot of times we have this old combination of ramucirumab, paclitaxel that has been there for like 12 years. And it's pretty toxic and not very effective. Then in third line, we have a couple of drugs so what happens is the patient becomes more and more symptomatic as they travel, and the treatments are less and less effective because we give the most effective first, second, most effective second, and least effective third, and after that we got clinical trials. And patients become more symptomatic, tumor becomes more resistant, and treatments become less effective as we go down the line. So when do you stop is, as Sam mentioned, there's no statement that one of us can make and say, this is when you stop. So what we do is we make sure that we don't harm the patient by treatment, So there are certain scenarios that we won't be able to decide online, but face to face with the patient and family, you can really come to a conclusion that further treatment is really harmful than helpful. And then, as you mentioned, the quantity of life with misery or quality of life with family without having to undergo tests and toxic treatments. So it's something like that. It's very, very hard to
Yeah,
answer that.
I agree. I didn't mean to give a hard question. It just is a hard question. There is no right answer for any broad answer to that question. Well, we've got 2 minutes left, and I'm going to ask Zeb this question from the chat about a hereditary diffuse gastric patient with a low, it sounds like, peritoneal carcinomatosis index score of 3. And there's talk about HIPEC and gastrectomy. This person was on Folfox and Nevo systemically, it sounds like. But maybe just to speak broadly a little bit about, do you ever think about peritoneal directed strategies in these very isolated peritoneal lesion type patients? Or how do you think about it?
I mean, I do think about it because I think you have to individualize care. You can't approach every patient the exact same way. I mean, if someone's behaving in a different way and you want to approach that cancer in a non-traditional approach, I think that's entirely reasonable. There's data for peritoneal directed therapies, whether it's um, surgeries or HIPEC. There's plenty of evidence. Not everybody considers it as good as systemic therapy. But if you have a patient with a rare situation, isolated situation, I think you have to think differently. So it's just got to be individualized, and that's kind of what I think all of us are saying. You have to think from the last speaker too that Jaffer pointed out is ultimately you have to trust the physician to help you make these good guidance decisions because it's not like there's an absolute right and an absolute wrong always. There's always a lot of gray.
Yeah.
I think any of us who've been treating patients for this long kind of know that.
I think that's 100% right. There's art and science, and it takes both. On that note, it is 9 o'clock. I want to be respectful of everybody's time. This was another great one. I'm sorry I didn't get to every single question. Please make sure to submit questions ahead of time. We'll make sure we get to them. There is a support group on the 13th of March with a webinar talking about gastric cancer prevention. And then the next town hall like this is about a month from now, April 7th, with Dr. Moy from Columbia and Dr. Citrin from Sloan Kettering. So everybody have a good night, and we'll do this again in a month or so. Thank you, Jeff.